much, Dr. Saad Behndi, to give us again an opportunity to interact with the world community of critical care today in this platform. And we are highly elated from India that we have been given a chance to talk on one of the most intriguing subjects in critical care, that is mechanical ventilation. With me, I have three prominent speakers. Dr. Bikram Gupta was leading one of the big hospitals in the UP state of India, the Banaras Hindu University, and from there he has now just shifted to another corporate with a very big name. He is a very leading intensivist in the eastern part of India, you can say. Dr. Sharmili is also from Odisha and the coastal region of India, where we have one of our best temples that we all visit, and beautiful scenarios. And from there, with those scenic beauties, today she will not be discussing that. She will be discussing on a very difficult subject, that is how to ventilate patients on ARDS. And with me, I have a very young speaker from Noida. It is just near the National Capital Territory of Delhi. Dr. Nazia, he's heading one of the big government medical colleges there, the Department of Anesthesiology, and she'll be telling us how exactly we might be ventilating the patient, but how we'll come out of ventilator from there. And myself, Dr. Ranajit Chatterjee, I am an intensivist for the last 20 years, doing all these nitty-bitties of ventilation, and I'll be discussing with you basically one of the most mind-blogging things in ventilation, that is loops and graphs and the asynchronies. I also am delighted to see Professor A. Sammanna. He is also an inspiration to everyone not only in the part of where he's belonging, but also to the mega people. Dr. Lopa Hasina Jahan has also joined from Bangladesh, and I'm indebted to her. She has given up time to join us. So without wasting any time, I'll ask Dr. Bikram Gupta to share his slides and start the first lecture today. I think, Dr. Bikram, we have around 25 to 30 minutes, and we'll discuss all the questions after all the lectures are over. Dr. Bikram.
Am I audible?
Yeah, you're audible.
So good evening, everyone. And at the outset, I would like to express my sincere thanks to Dr. Saad Behndi sir and Ranajit Chatterjee sir for giving me this opportunity to discuss in this anesthesiology seminar, anesthesiology online courses in the mechanical ventilation symposium. The topic is given to me and allotted to me is the modes of the mechanical ventilation. So I will try to justify this topic. So let's start with this presentation. So history of this mechanical ventilation has been started centuries ago, and with the positive pressure ventilation with the use of the bellow mechanism. But it was claimed that it causes a lot of lung injury, and then the use of this was abandoned at that time. After that, it takes many years, and then the concept of negative pressure ventilation and this negative pressure ventilator has been started, and the use and the utility of this ventilator used in this during the polio epidemics. And we all familiar with the iron lungs, and that iron lung saves a lot of life during that polio epidemics. And then again, the popularity of the positive pressure ventilation has been started, and providing ventilation in the next 50 years, great development has achieved in this mode or positive pressure ventilation. So my whole discussion is mainly on the positive pressure ventilation. And the Dr. Robert Kamarick from the Harvard University described the development of this isomechanical ventilator during this second half of the 20th century into the 4th generation. The first generation, second generation, third generation, fourth generation. The first generation includes only in the era of 1940 to 1960, which only include the volume control ventilation that enable to patient to trigger the ventilator, and there is no PEEP in the first generation of the ventilators. Then this second generation of the ventilation introduced during the mid 1970 to the early 1980, and the generation was very similar to the previous one, but it has included only the patient triggering capability as well, and the basic allowance for the high pressure, high rate, and the low tidal volume. Then there is introduction of this third generation ventilation in the late 90s, and the ventilation during this time become more sophisticated. One of the improved features was the computer microprocessor to control the breath delivery. It has a flow triggering capacity, as well as adding the extensive alarm and the monitors and waveforms as well, that will represent the pressure, flow, volume, waveforms, scalars. And then now last one is the fourth generations. We are on this era of the fourth generation. This mainly start in the late 90s, and they are still developing until present time. These ventilators are characterized by the complexity and versatility, and it is mainly based on the closed loop mechanism. This type of many of the companies are still updating the software, and to improve the patient's quality as well as minimum complications of the mechanical ventilation to the patients. So what is the modes of the mechanical ventilation? It is a set of operating characteristics that control how the ventilator functions. And operating modes prescribe the way of a ventilator is to trigger into the inspiration, then cycle into the expiration. The variables which limit during the inspiration and allow the mandatory or spontaneous breath or both. So I will discuss these modes of the mechanical ventilation in the next 20 to 25 minutes. Now this first thing is the control mandatory ventilation. It includes both volume control as well as the pressure control. This both control modes of the ventilation has the time triggered and the time cycle. In this volume control, we have to set the volume, and that volume will be achieved by the variable pressure, and the flow will be the constant flow. In the pressure control, we have to set the pressure to achieve the target volume. This pressure, we have to set the peak inspirative pressure as well as the positive index pressure, and the gradient of that will decide the target volume which we want, and that flow is the descending flow to maintain the pressure. In both modes, we have to fix the inspiratory and the expiratory ratio, respiratory rate, presence or absence of inspiratory pause. But in the pressure control, we have to set the pressure limit to achieve the target volume, and the volume control, we have to set the target volume or tidal volume. This mode of the ventilation we can use in the patients which have the neurological injury. You want to keep that patient for the elective ventilation, or the patient of the tetanus, or in case of the patient having in the initial period of the mechanical ventilation where a lot of patient ventilator synchrony was there. But there is certain problem this mode of the ventilation, and the most important problem is the diffuse atrophy of the diaphragm. So considering that the mode which modified from the control mode of the ventilation to the assist control mode of the ventilation, and in which the patient trigger was sensed by the ventilator, and after sensing that, ventilator will deliver the set tidal volume to the patients. So this assist control mode, either the pressure assist control or volume assist control, each breath either assist or control delivers the preset mechanical tidal volume. Depending on if the patient is not triggering, that the ventilator itself give the time triggered breathing, and if the patient is triggering, then mechanical ventilator will deliver by sensing that. And the cycling is a volume cycling or pressure cycling, depending on which pressure assist control or volume assist control. It has a certain advantage and disadvantage. Advantage like decreased work of breathing. It will provide the better patient ventilator asynchrony, so less ventilation perfusion mismatch, and this is most important thing, it will prevent the diffuse atrophy of diaphragmatic muscles. Disadvantage, like because I already said the patient triggered. If the patient is triggering, then ventilator will sense, and because of that, there is high minute ventilation, and that will create the alveolar hyperventilation. There is chances of development of high intrinsic PEEP, mainly in case of the COPD patients, and increased mean airway pressure causes the hemodynamic disturbance as well. Now moving to the next mode of the ventilation, that is the intermittent mandatory ventilation. And this mode of the ventilation developed because we want to allow the patient to take the spontaneous breath. So this mode of the ventilator deliver the preset number of time cycle mandatory breath, as well as allow the patient to breathe spontaneously at any tidal volume in between. Advantage, because we are allowing the spontaneous breath, so lesser sedation, lesser VQ mismatch, and less hemodynamic instability. Disadvantage, major disadvantage is the breath striking, and because of that, barotrauma to the patients. And this is the graphics of the intermittent mandatory ventilation that we'll discuss by the Ranaji Chatterjee sir in the next lectures. Now coming to the next mode, there is synchronized intermittent mandatory ventilation. In this, ventilator delivers either assisted breath to the patient at the beginning of a spontaneous breath or time-triggered mandatory ventilation breaths. There is synchronization window to prevent the breath stacking that is major problem in the intermittent mechanical ventilation, and synchronized window is the time interval just prior to the time trigger. Because of that, breath stacking is avoided as mandatory breaths are synchronized with the spontaneous breath. In between the mandatory breaths, patient is allowed to take the spontaneous breath at any tidal volume. So SIMV breath, the characteristics of ventilator delivers the mandatory mechanical ventilation and patient can take the spontaneous in between. Mandatory breath is the time triggered or patient triggered, and spontaneous breath are the patient triggered. Cycling mechanism, mandatory breath is the volume cycle and this spontaneous breath is the flow cycle. So look here, in this SIMV mode, patient is taking the spontaneous breath in between the mandatory breath. If you are giving the support, then this is the sinusoidal pattern of the wave. That is, it means the spontaneous breathing. If patient is not achieving that adequate tidal volume, that we can provide or support the pressure support to this spontaneous breath, and then the cycling, this waveform will change from the sinusoidal wave pattern to the descending flow pattern. Indications, primary indication is to provide the partial ventilative support. Advantage, it maintains the respiratory muscle strength, so avoid the muscle atrophy. It will reduce the VQ mismatch, decreases the mean airway pressure, and it will help to facilitate the weaning of the patients. But there are certain complications with this mode, and now this mode was mainly not used for the weaning, also because there is chances of more weaning failure. And the complications with this mode is that you desire to wean the patient too rapidly. Because of that high work of breathing, spontaneous breathing, that will lead to the muscle fatigue, and there is chances of the weaning failure. Now moving to the next mode, the pressure support ventilation, and it will mainly use to lower the work of spontaneous breathing and augment the spontaneous tidal volume. Apply a preset pressure plateau to the patient's airway for the duration of spontaneous breathing, and the patient, this breathing is patient triggered. Tidal volume varies with the patient's inspiratory flow demand. Inspiratory lasts as long as patient actively inspires, and inspiration ends when the patient's inspiratory flow demand decreases to a preset minimal value. So we have to set the expiratory trigger sensitivity. If you are putting if you are putting that 60%, then when the maximum flow is measured as 100%, when the maximum flow comes from 100 to 60%, then automatically the cycling goes from the inspiration to the expressions, like here. So when the flow is decreased from here to here, then the inspiration goes into the expression part. So you can see here, these are the scalars, pressure time, flow time, and the volume time scalars. So this, in this pressure support ventilation, the mode, the mechanical breath is triggered by the patient. Cycling is the flow cycling, and then pressure limited mode. Here we have there is a already CPAP is applied, and above that we have to set the pressure support. So this helps to wean the patient whenever we are considering that patient can wean from the ventilators, or we have treated the patient, we have treated the reversible cause, then we can try to give the spontaneous breathing trial with this pressure support ventilation. So this pressure support ventilation also applied with the SIMV mode during the spontaneous ventilation to facilitate the weaning. It helps to increase the patient's spontaneous tidal volume. It helps to decreases the spontaneous respiratory rate as well. So work of breathing is also decreased, and the addition of this of extrinsic PEEP to the pressure support increases its efficacy. So you can see here the pressure support is applied with the SIMV volume control mode. So we can see here there is the application of pressure support. The flow become now the descending type of the flow pattern, and then tidal volume is more because of this pressure support. Now coming to the continuous positive airway pressure, and this continuous positive airway pressure is just like a PEEP, that is the positive inexpirative pressure applied to airway of a patient who is breathing spontaneously, and it is mainly used in case of the refractory hypoxemia if the patient is able to maintain the adequate spontaneous ventilation. So these are the basic modes we are mainly using in our hospital, in our ICU to treat the patients, but there is development of newer modes of the ventilation. And why there is need of the newer modes of the ventilation, it will mainly address, because we have already seen this basic modes, with this basic modes, a lot of patient ventilator asynchrony. So the company and many clinicians wants to reduce that patient ventilator asynchrony. So this, whether this newer modes of ventilation will help to address that patient ventilator asynchrony or not, or this newer mode ventilation can help to physician or respiratory therapist to win that timely and early, and it's just a marketing gimmicks. So let's discuss about that. This is mainly based, this all the newer modes of the ventilation is dual control modes. That is dual control modes means in the each breath there is change of in intra breath and inter breath. In the intra breath, in the same breath there is change of the volume cycle breath to the pressure cycle and the pressure cycle to the volume cycle, and breath to breath there is change of the this mode of the ventilation in the one breath to the another breath to achieve the target pressure or target volume. So in the dual control within a breath, the examples are this volume assured pressure support and the pressure augmentation. Dual control breath to breath, that is further subdivided into the pressure limited flow cycle breath or pressure limited time cycle ventilation. So in the pressure limited flow cycle ventilation, the examples are the volume support and variable pressure support. In the dual control breath to breath, the example is the pressure regulated volume control, PRVC mode, adaptive pressure ventilation, autoflow or volume control plus. Dual control breath to breath, again, another example of this is adaptive support ventilation. So let's discuss each of these modes. So first one is the volume assured pressure support. This volume assured pressure support based on the feedback loop, and that the feedback loop depends on the basis of the volume. So switches even within a single breath because the intra breath. So single breath from pressure support to the volume control, if the target volume or minimum target volume has not been achieved. So the control here is either the pressure and volume, because it will changes into the intra breath from the pressure to the volume. So trigger by the patient, limit is the pressure, target is the volume here, and if it is pressure control, then the cycling is the flow, and if it is the volume control, then the cycling is the volume. So look here in this diagram, we have to set the pressure limit, and then in this pressure limit, the set tidal volume cycle threshold achieved. And because of this pressure, we are putting the patient in the pressure mode, pressure support ventilation. So this flow is the descending type of the flow. But look here, the tidal volume is not met. So because of that, the descending flow is changed into the constant flow to achieve that tidal volume which an operator sets in the ventilator. So, and that tidal volume will achieve by increasing the pressure limit. So the pressure limit becomes the override. So look here, there is change of this mode of the ventilation intra breath. Here is the pressure support, and now this is descending flow, and now from the changing of the descending flow to the constant flow, that is the volume support, and to achieve the target volume. So what are the advantage of this mode of the ventilation? Because of this pressure support, there is high initial flow, provides the better gas mixing, reduces flow dysynchrony during the assisted breath, and volume guaranteed ensure a constant tidal volume. That is very important. But drawbacks, there is no robust data and availability is still present, not used in the worldwide, and not available in the new ventilators as well. Now coming to the breath-to-breath dual mode of the ventilation, and in this, the example is the volume support, and here the control is the pressure, triggered by the patient, limit is the pressure, target here is the volume, and cycling was the pressure control, so cycling is the flow cycling. So there is, when we are putting the patient, we have to start with the 5 centimeter S2 of the pressure, and in this pressure the test breath will measure how much starter volume will achieve by the ventilator, and then gradually the pressure limit will increase, and maximum increase at the maximum increase 5 centimeter below the upper pressure limit. So after achieving that target volume, if the patient will able to achieve that tidal volume, then gradually the pressure support will decreases. If the patient trigger breathe, then volume support breath is patient ventilator will provide the volume support breath. If patient is not able to training and there is apnea alarm, then this volume support modes will change or switch to the PRVC mode. I will discuss about this in the later slide. So this is the volume support mode, and now coming to the pressure regulated volume control mode, and we are using this, and we are very familiar with this pressure regulated volume control mode, all the intensives. The other names of this pressure regulated volume control is the auto flow, that is with the Drager medical AZ, and the volume control plus with the Puritan Binet. So what is the mechanism of this pressure regulated volume control? The test breath is given that measure the tidal volume, and that measured tidal volume is compared with the set tidal volume which we have set in the ventilator. If it is equal with the same inspiratory pressure, or if it is less than measured tidal volume is less than the set tidal volume, then the inspiratory pressure will increase, and to try to achieve that measured that set tidal volume. If this is more than set tidal volume, then inspiratory pressure will decrease, and again this try to maintain the set tidal volume, and this vicious cycle is going on, and then that will mainly maintain the set tidal volume by increasing and decreasing the inspiratory pressure to maintain the target tidal volume. So for this we have to set the following parameters in the PRVC mode. Minimum tidal volume we have to set, minimum respiratory rate as well, then TI or inspiratory expiratory ratio, and upper pressure limit. Machine will deliver a maximum pressure less than 5 centimeter of set value. We have to keep the FI2 to maintain the this SQ2 level, and then PEEP as well. What are the benefits of this PRVC mode? It guaranteed a maximum average tidal volume. So the benefit of PCB retained, better flow synchrony, pressure automatically adjusts for change in compliance and resistance within a set of range. So the tidal volume is guaranteed. It limits the barotrauma and as well as prevents the hypoventilation. But certain disadvantages and the risks as well with this mode of the ventilation, because it can vary the mean airway pressure. It causes the or worsen the auto PEEP as well. When the patient demand increase, the pressure level may diminish when the support is needed. This is very important. May be tolerated poorly in the awake or non-sedated patient, and a sudden increase in respiratory rate and demand may result in decrease in ventilative support. What is this auto mode? And this auto mode is actually this is the combination of PRVC and the volume support mode. So when the patient is in the apnea for 12 seconds, then automatically patient goes into the PRVC mode, and that is the ventilator triggered pressure control and time cycle mode. And if the two consecutive spontaneous breath is present, then that PRVC mode again shifted back to the spontaneous mode, and that spontaneous mode is the volume support mode. So the volume support mode is a patient triggered, pressure limited, and flow cycle. If there is if the patient is not triggering and the apnea for 12 seconds, then this volume support mode is again goes back to the PRVC mode. So it is interchangeable. It depends on the patient effort present or not. And if the patient is taking breath, then it volume support will work. If the patient is not taking breath, there is apnea, then PRVC mode will work. Now there is new way of thinking that old philosophy is that confirm the patient to the ventilator. And because of that, a lot of the problem like potential for ventilator associated lung injury, inferior gas distribution, ventilator associated pneumonia, and there is a lot of the patient ventilator synchrony. And because of the patient discomfort, we are putting the patient on the ventilator. Patient require a lot of sedative drugs, and there is chances of increased length of ICU stay and cost as well. So a problem can never be solved on the same level of thinking that identified it, according to the Albert. So now the concept is from confirming the patient to the ventilator. Now it's changing to the confirm the ventilator to the patient. And by keeping this idea, the new way of newer modes of the ventilation is that the airway pressure release ventilation. And in this, we are confirm the ventilator to the patients, not the patient to the ventilator. And what is this airway pressure release ventilation? It is similar to CPAP. As a patient breathe spontaneously, this airway pressure is maintained at moderately high level. That is the 50 to 20 centimeter of water throughout the most of the respiratory cycle, with the brief period of lower pressure to allow the deflation of the lung. So in this increased pressure, it ensures the alveolar recruitment and the oxygenation as well. And we are allowing the brief duration to allow the elimination of CO2 without the alveolar collapse. And it is indicated as an alternative to the conventional volume cycle ventilation for patients with a decreased lung compliance, like in case of the ARDS patient, as there is less chances of barotrauma with this APRV modes, because it will create the less big airway pressure. We are keeping the two set of the CPAP level in this, high CPAP and low CPAP, high pressure and low pressure level, and then two time level. So the both pressure level are the time triggered and the time cycle, and we are keeping the inverse ratio ventilation, mainly the that is the I ratio should be the inverse. So it will causes the increased mean airway pressure that will help to the alveolar recruitment, mainly in case of the refractory hypoxemia of the ARDS patient. So by keeping the more inspected times, because of that mean airway pressure will increase, that will open up the this bronchioles, and there is more chances of the oxygenation. So in this APRB mode, patient can able to take the spontaneous breath and during the high pressure as well as the low pressure, and that will the greater advantage of this APRV mode, and that will help to recruiting and also help to come out with the refractory hypoxemia as well. What are the advantage of this APRV mode? It allows the inverse ratio ventilation. I already discussed. It improves the patient ventilator asynchrony because we are allowing the spontaneous breathing to the patients. It help because we are keeping the high inspiratory time, so it improves the mean airway pressure, so that will help to resolve the refractory hypoxemia as well. Improve the oxygenation by stabilizing the collapsed alveoli and allow patient to breathe spontaneously while continuing the lung recruitment, and decrease the physiological dead space as well. What are the disadvantages? Variable tidal volume. It could be very harmful to patient with the high expiratory resistance like COPD patient or asthma patient, because it will create the auto PEEP because of that increased mean airway pressure, and we want to avoid the auto PEEP or this intrinsic PEEP in the case of the COPD and asthma patient. So we are that will be the very harmful mode for the COPD and asthma patient. Caution should be used with a hemodynamically unstable patient, because of that auto PEEP it causes the decreased venous return, and ultimately the patient becomes hemodynamically unstable. Asynchrony can occur if the spontaneous breath are out of the synchronization with the release time. Now coming to the next mode, the closed loop system, and this is the now the coming with the most of the ventilators. And what is this closed loop system? It is mainly the based on the microcomputer technique system that allow the ventilator to manipulate the variable based on the feedback. And initially the initial generation of ventilation is also based on the feedback, but it is mainly single variables. It is based on a single variable, but this type of closed loop systems, ventilator will change their variable change their parameters according to different variability. So it's based on the different feedbacks mechanism, and it is the depends on the commercially multiple modes available today. So what are the modes? This is the proportional assist ventilation, NAVA, adaptive support ventilation, and the smart care. These are the advanced version of the pressure support ventilation or pressure control ventilation, and there's mainly inputs from the neural output in the NAVA. So we will discuss. First thing is this neurally adjusted ventilator assistance mode, the NAVA mode. What is this NAVA mode? Is a relatively newer mode of the ventilation in which a ventilator utilizes the electrical activity of the diaphragm. This is the electrical activity of diaphragm to generate the appropriate breath in the assisted ventilated patients. So in the conventional ventilator, the triggering mechanism, the central nervous system give the stimulation to the phrenic nerve, then there is a diaphragm excitation, then diaphragm contraction. Because of that, the chest wall or lung expansion, and there is change in the airway pressure, flow, and volume, and that will be sensed by the ventilator, and then it gives the battery breath on the basis of set parameters. which will be done by the operators. But in this NAVA, when the diaphragm excitation occurs, and that will be sensed by the this mode of the ventilation, and then accordingly that will give the tidal volume to the patients. So conventionally, a pressure drop or flow reversal is used to initiate the ventilative support in the conventional triggering. But in this NAVA, the earliest signal that can be registered is the excitation of the diaphragm, that is excitation of the diaphragm, and adjusting the support level in the synchrony with the rise and fall of the electrical discharge, the ventilator and the diaphragm work with the same signal input. So it will help to better patient asynchrony, better sleep quality. It will be very helpful for the lung protection because it decreases the risk of the barotrauma as well as the volume trauma because it depends on the diaphragm excitation or neural output. Less sedation is needed and the patient is more comfortable, and there is very less chances of the diaphragm atrophy and dysfunction. Now the feedback control of ventilator breath delivery based on the respiratory system mechanics, and the example is of this feedback mechanism is the adaptive lung ventilation or adaptive support ventilation. And this is mainly modes supplied by the Hamilton Medical Devices. So this adaptive support ventilation is based on the minimal work of breathing concept developed by the Otis et al., which suggests that the patient will breathe at a tidal volume and the respiratory frequency that minimize the elastic and the resistive loads while maintaining the oxygenation and the acid-base balance. So in this mode, we can see these are the conventional mode of the ventilation, and in this we are putting the patient on the ASB mode, the adult mode. Here we are putting a lot of parameters. We are setting a lot of parameters like the pressure control, pressure support, TI, tidal volume, respiratory rate, I ratio. But here we just keeping the percentage of minute ventilation, and 100% means it will give the 100 ml per kg of the minute ventilation to a patient. And it will mainly help to the CO2 elimination and the patient support as well. So this part will help these parameters in the conventional ventilator to help out the this CO2 elimination and the support to the patients by achieving the minute ventilation. But here in this ASV mode, we just keeping the minute ventilation with just setting the minute ventilation. So it will help to the CO2 elimination and patient support. So we'll have to set only one parameters in the adaptive support ventilation. For the oxygenation, in this conventional mode of the ventilation, we are for improving the oxygenation, we have to set the P for CPAP and as well as the FiO2 percentage. Same here, we have to, for the oxygenation part, we have to set the P for CPAP and the FiO2 part. So we can see here, this is the mainly the this is the graphics of the adaptive support ventilation, and this one denotes the x-axis, that is the respiratory rate. 2 denotes the tidal volume in the y-axis, and this is the third one is the minute volume curve. This is the minute volume curve, and this is fourth one is the mainly the safety frame. This is the safety frame, this red square, and that is defined by the lung protective axis. And then this is the fifth is the target point that is formed by the intersection of the measured tidal volume. So here is the measured tidal volume and the measured respiratory rate. So here you can see here the respiratory rate, measured respiratory rate, and measured tidal volume, and the intersection of that will provide the safety curve range target points. And then this sixth number is the mainly the current patient's value that is formed by the intersection of the measured tidal volume and the current respiratory rate. So this adaptive support ventilation continuously adjusts the setting to keep the patient within the target zone, that is in the red zone area, and guides the patient's current value, that is this current value, this is the yellow cross, to the target points. Always try to achieve the patient to this target point, that's the green circle, for both as well as active as well as passive patients. When the patient condition meets the target point, if the patient is able to maintain this target point, then patient is considered optimally ventilated according to the adaptive support ventilation. This is the smart mode of the ventilation. Why ASB? It is intelligent mode of the ventilation for passive as well as spontaneously breathing patient and the pediatric patient as well. Automatically adjust the ventilation to the lung mechanics and apply the lung protective strategy as well. And it will also help to shorten the ventilation time. Now coming to the next mode, the high frequency oscillatory ventilation. Now it is not recommended as per the Oscillate and Oscal trial. So the only I just want to discuss one slide for this. This it prevent the ventilator-induced lung injury. It based on the biased flow and piston pump oscillate at the frequency of 3 to 15 hertz. Tidal volume we have to set the 1 to 3 ml per kg. Now it's mainly used for the neonate patient for neonate patient only, and ventilation may be increased by decreasing the oscillations frequency. So to conclude my presentation, the principle of ventilation are probably more important than mode used to honor these principles. The older modes of the ventilators is the passive and operator dependent tools. The newer modes, in the newer generation of the ventilator, it is mainly adaptively interactive modes. It try to reduce the patient ventilator asynchrony. It is goal oriented and patient centered modes. A mode of ventilation is only as good as the operator who applies it. If you are not idea about that, then you will create the more problem. You will create the more lung injury. So the mode of ventilation is only will be helpful when the operator will knows everything about that, and not all the glitters is the good. So thank you very much. If you have any questions, then we can discuss.
Thank you, Dr. Bikram, for such a lucid presentation. And those who are working on ventilators, they will know that the best way of learning ventilator is to stand by the bedside, and whatever newer machines are coming up, what are the generations going on after the 4th generation, ultimately it has been found that no mode is superior to one another when mortality is concerned. It is best to use that mode in which you are most comfortable. Yes, there are newer modes like Smart Care, NAVA, which are coming up, and they are being used more frequently in patients and making our job much easier so that we can use our mind much easier. So we'll accept the questions after at the end.